Hi everyone, I am Dong-Hyun from Department of Orthodontics, Chonnam National University, Gwangju, Korea. It is a great honor for me to introduce our recent study. Cephalometric radiographs were introduced in orthodontics by Broadband in 1931 for the diagnosis, growth, and treatment of craniofacial skeletal morphology. Orthodontists continue to use cephalometric analysis for orthodontic diagnosis and treatment planning. However, 2D cephalogram have limitations because of the 2D projection of a 3D object. Objects appear larger than their actual size, and any tilt or rotation of the patient's head can affect the results, leading to errors. To perform orthodontic diagnosis and treatment planning with 3D images obtained through CBCT, it is warranted to obtain 3D cephalometric values. However, there are no normal data for 3D cephalometric values. Currently, the normal data for cephalograms are for 2D steps obtained after the development of the cephalography device in 1931. Because of the limitations of 2D steps, the normal data for 2D steps cannot be employed to 3D steps. This study aimed to obtain normative data for 3D steps in the Korean population and compare this data between groups with different skeletal patterns to identify differences and prove the clinical validity of the normative data obtained. Individuals were recruited from among patients who underwent diagnostic examinations at the Department of Orthodontics, Chonnam National University Dental Hospital, Gwangju, between 2010 and 2023. Individuals were divided into 3 groups based on their vertical skeletal pattern according to the Cephalometric plane to mandibular plane angle value, as determined by 2D cephalometric analysis. Only the normal divergent group was selected, and further subgroups based on the A and B value into skeletal class 1, skeletal class 2, and skeletal class 3. From the skeletal class 1 normal divergent patients who satisfied the inclusion and exclusion criteria, 30 males and 30 females were selected in decreasing order of age. Similarly, from the skeletal class 2 normal divergent and skeletal class 3 normal divergent patients, 15 males and 15 females were selected from the pool of individuals in ascending order of age. The reconstructed CBCT 3D images were reoriented. The median was set as the origin of the coordinate axis. The x-axis was set as the plane parallel to the Frankfurt horizontal plane while passing through nasion. The y-axis was set as the plane perpendicular to the horizontal plane while passing through nasion and basion. The z-axis was set as the nasion perpendicular plane passing through nasion and perpendicular to the mid-sagittal plane and horizontal plane. After defining the landmarks in the hard and soft tissues, they were designated from the reoriented 3D images. In this study, landmarks in both the hard and soft tissues were manually defined by the author. The tracing function was utilized for 3D analysis with the in vivo 5 software, and the axial, sagittal, and corner section views were used to specify the exact landmarks. For skeletal analysis of the oral and maxillofacial regions, sagittal, vertical, and transverse measurements were established and subdivided into skeletal, dental, and soft tissue measurements. Additional measurements were also performed to assess mandibular asymmetry and the sagittal, vertical, and transverse positions of the condyle. And here are the results. Intergroup comparisons of hard and soft tissue measurements on 3D cephalograms shows statistical significance for several measurements of the sagittal relationship, occlusal plane angle, and palatal depth in the vertical relationship, and maxillary intermolar width in the transverse relationship between class 1, 2, and 3 groups. Comparisons between skeletal classes 1, 2, and 3 in males and females were consistent with these results. In comparison among skeletal class 1, 2, and 3 groups, the vertical relation measurements showed the statistical differences in the occlusion plane angle and palatal depth, with the skeletal class 2 group showing greater values compared to the skeletal class 1 and 3 groups. In the transverse relation measurements, only the maxillary intermolar widths revealed a significant difference, with skeletal class 3 group having a higher value than skeletal class 2 group. Asymmetric analysis of the mandible and soft tissues revealed significant differences in mandibular body length and gonial angle, with the skeletal class 3 group showing higher values compared to the skeletal class 2 group. Condyle position was not significantly different among the groups. In the comparison of bilateral mandibular measurements between right and left sides, since the symmetry individuals were included in the study, no statistically significant differences were found between the right and left sides. Based on the present results, we concluded that 3D cephalometry can serve as a universal solution to the limitations of traditional 2D cephalometry and decrease unnecessary radiation exposure. This study introduced a new 3D cephalometric measurement and Korean normative data, validating its effectiveness by comparing values across different skeletal classes. These findings offer initial insights into craniofacial structure for variations among numerous skeletal types, and may prove valuable for future orthodontic diagnosis, treatment planning, and anthropological research using 3D cephalometry. And I'd like to thank my co-author and my supervising professor for their great collaboration. This article is now available as an online or print publication on the KJ website and will appear in the 2025 issue. Thank you.